Chalo bachcho, let's start now with the last session for today. That will be now the management of the breast cancer. Okay. So if I talk about the management of breast cancer, beta, the first one which is there is nothing else but early invasive breast cancer. मैंने बोला था early invasive breast cancer, that means the stage 1 and the stage 2 of breast cancer, beta, right? Now when I talk about the early invasive breast cancer, here definitely, beta, the size of the cancer would be lesser, and even the number of lymph nodes which will be involved, beta, they will also be less. So here what we have to do in this condition, can I try to save some amount of breast tissue, beta? Yes. So that means what? I'm trying to conserve the breast, beta. Therefore, this is what is called as the breast conservation surgery. What do I do in this? I only remove the lump, beta, with some normal margins, bache, or I only remove the quadrant in which the patient is having the cancer. Yes, I do not remove the whole breast of the patient, either only a lump or only the quadrant. So here I am trying to conserve the breast, and that's the reason this surgery which will be there, beta, will be called as a BCS, and that BCS is a breast conservation surgery. Now please tell me, beta, in a patient of cancer, when you do a breast conservation surgery with some normal margins only, you're not removing the whole breast. That means the chance of recurrence will be more or less. Obviously, the chance of recurrence will be very high. That's the reason, beta, it's always mandatory that whenever we go for a breast conservation surgery, it should always be followed by, okay, a radiotherapy. So because if you give radiotherapy after the breast conservation surgery, the chances of recurrence will be lesser. That is one option. Another option, beta, for example, if a female says, Doctor Saab, I do not want any risk of cancer again. Okay? I do not want any kind of recurrence again. So in that patient, what we can do? In that patient, we can actually remove the whole breast tissue itself. Yes. In that female, we can remove the breast tissue, the pectoral fascia, and the nipple areola complex together. And that will be called as a simple mastectomy. Okay, mastectomy is what? Removal of breast, beta. So in early invasive breast cancer, beta, there are two types of surgery. Okay, the first one is a breast conservation surgery followed by radiotherapy. The second option is a simple mastectomy, that is removal of breast. Next important, beta, if I talk about the second is nothing else but locally advanced breast cancer. Now, in case of locally advanced breast cancer, beta, obviously the size of the tumor is larger. The number of lymph nodes involved will be more. So what we do in this condition, understand, beta, in a patient of locally advanced breast cancer, the first aim is to definitely decrease the size of the cancer. And obviously, beta, if we are going to decrease the size of the cancer, even the stage of the cancer is going to decrease. So the first thing that we do before the surgery, beta, is giving neoadjuvant chemotherapy to the patient. The first thing that we have to do, beta, is nothing else but giving a neoadjuvant chemotherapy to the patient, bache. Okay. And what is the reason for giving neoadjuvant chemotherapy to the patient? The reason is definitely downstaging the cancer, beta. The reason definitely is nothing else but downstaging of cancer. We have to downstage the cancer, beta. That is the reason we are giving neoadjuvant chemotherapy to the patient. Okay? After giving neoadjuvant chemotherapy, beta, what should be the next step? The next step which is there, beta, it is nothing else but doing a surgery. Now in this surgery, beta, we cannot only remove the breast tissue. Along with the breast tissue, we also have to remove the lymph nodes which have been involved, beta. Okay, it is a locally advanced case. That's the reason, beta, we have to remove the breast tissue along with the lymph nodes. And that's the reason, beta, we are going to call it as radical mastectomy. Okay, and nowadays we obviously perform which kind of mastectomy, beta? We perform a MRM. What is MRM? Modified radical mastectomy. So after the size of the tumor has been decreased, beta, obviously you will go for a modified radical mastectomy in the patient. Okay, in modified radical mastectomy, obviously you have to remove the breast tissue, the pectoral fascia, the nipple areola complex, along with that, beta, all the level 1, 2 and 3 axillary lymph nodes. Okay, so MRM or the modified radical mastectomy would be done, and followed by that, beta, as it is a locally advanced breast cancer, so the chance of recurrence will be very, very high. And as the chance of recurrence is very high, beta, we should definitely give radiotherapy to the patient, beta, after the surgery, because radiotherapy after the surgery will definitely decrease the risk of breast cancer, beta. It will definitely decrease the risk of breast cancer. This has to be remembered. Clear? So neoadjuvant chemotherapy followed by MRM, that is modified radical mastectomy, followed by a radiotherapy. That is the mainstay of management in a patient who is having a locally advanced breast cancer. Now, next important beta if I talk about is the advanced breast cancer. Advanced breast cancer, which is there beta, it is nothing as but stage 4 breast cancer. That means any T, any N, but M1 distant metastasis is present. And as I told you, beta, when the cancer has spread outside the breast, when distant metastasis is already present, no surgery is going to work in that patient, beta. Okay? Because from where you are going to remove the surgery, from where you are going to remove the cancer, you can remove it from here, not from the other sides, right? So that's the reason. In last stages of cancer, you might have heard, na, nothing could be done. So that is nothing as but stage 4 of the advanced cancer, beta. And here, as I've told you, Bhagwan Bharose, that means your patient will be given a palliative care, beta. Okay, and the aim of palliative care is what? First is to improve the survival of the patient, and second, to improve the quality of life. And please remember, beta, this palliative care in the patient which is there, beta, it is usually done with the help of chemotherapy. Yes, we give chemotherapy to the patient, beta, for the purpose of palliative care. And which is the new chemotherapy drug that is added, beta? There are multiple drugs, but one monoclonal antibody which was recently added in the chemotherapy of palliative care, and that was pembrolizumab, beta. So pembrolizumab is the drug, beta, which is usually given in the chemotherapy of palliative care in a patient of a advanced breast cancer. Clear about? So that has to be remembered. No issues with this, anybody? So pembrolizumab, do remember that name? Okay, hopefully that's clear to all of you. Chalo. Now, next important beta, let's talk about these surgeries. Okay, let's talk about the BCS, simple mastectomy, radical mastectomy in details now. Done. If I talk about beta, the surgeries now, the first one which is there, beta, is going to be your breast conservation surgery. I've told you, beta, in the BCS, that is your breast conservation surgery, which either I have to do a lumpectomy or we just have to do a quadrantectomy. That is, we don't remove the whole breast tissue, rather we only remove the breast lump or the quadrant affected, beta, with some normal margins. And how much should be the normal margins, beta? So yaad rakhna, the normal margins for a breast conservation surgery, they should be, beta, 1 centimeter normal margin should be taken. And for which kind of a cancer? For an invasive kind of a cancer, beta. Okay, 1 centimeter ke normal margins have to be taken, beta. 1 centimeter normal margins have to be taken for an invasive cancer. Okay, so invasive cancer ke liye 1 centimeter normal margins are taken. No issues with this, anybody? So that is important, beta. Next important, as I've told you, it is mandatory, beta, that every patient who is undergoing a breast conservation surgery should always go for a radiotherapy after the surgery. Why? To prevent the recurrence. Because after a breast conservation surgery, there is a very high risk of recurrence, beta. So radiotherapy is mandatory, beta, after a breast conservation surgery due to a very high risk of recurrence. Now, in which conditions a breast conservation surgery will be contraindicated? What are the conditions where a BCS should not be done, beta? The first and the foremost condition, beta, has to be pregnancy. Why? We know, beta, definitely in pregnancy, can you give a radiotherapy? No. And if radiotherapy cannot be given, a breast conservation surgery should not be done, because then the patient will have a very high risk of recurrence. Okay? Next important, beta, if the patient is having a multicentric cancer. Now, what do I mean by multicentric cancer, beta? The cancer is basically present in multiple quadrants of the breast, beta. So obviously, if the cancer is if the cancer is present, beta, at multiple sites in multiple quadrants, will it be possible for you, beta, to save the breast? No, here majority of the breast had to be removed. So kya matlab hai BCS karne ka then, right? And the recurrence will also be very high. Next important, beta, other contraindications. These are relative contraindications, beta. Those relative contraindications are: one is prior radiotherapy to a chest. If the patient has already received a radiotherapy to the chest, beta, again if you give a radiotherapy, beta, after a BCS, the chance of secondary cancers or malignancies is going to increase. We know now that radiation is also one of the important risk factors for cancers. So if you keep on giving radiotherapy a lot of times, patient will have a high risk of cancer. Next important, LABC, beta. Obviously we know breast conservation surgery is only done for early invasive breast cancer, not for a locally advanced breast cancer. Locally advanced breast cancer ke liye, it is not possible at all to do a BCS. Next, large tumor to breast ratio, beta. The tumor is so big that it is not possible only to save the breast now. So obviously in this kind of a breast cancer, beta, obviously we should not go for a breast conservation surgery. Next important, multifocal. Multifocal means what? Here definitely, beta, the cancer is present only in one quadrant basically, but there are multiple foci of that cancer. Okay, there are multiple foci of that cancer. Again, beta, the risk of recurrence is high. Next important, collagen vascular diseases. Collagen vascular diseases are nothing else but connective tissue disorders beta. That means the female suffering from SLE, scleroderma. In these females, if you definitely give radiotherapy beta, they have worsening of symptoms. Yes, their symptoms actually worsen beta. And therefore, radiotherapy cannot be given. And if radiotherapy is not given, BCS cannot be done. Clear? So these are the conditions beta where a breast conservation surgery should be contraindicated. Okay, the two important ones you have to remember. Now let's talk about mastectomy. Which if I talk about mastectomy, we know mastectomy means removal of the breast tissue. बराबर है? Mastectomy is removal of the breast tissue. So first one is simple mastectomy beta. What do we remove in a simple mastectomy? First thing, in a simple mastectomy beta, we have to do the removal of breast plus the nipple areola complex. You can write it as MAC in the bracket, NAC in the bracket. Okay, you have to remove the nipple areola complex beta. You can write NAC in the bracket. Plus, you have to remove beta the pectoral fascia because it is very commonly involved. Okay, because breast is lying on that itself. So please remember removal of the breast tissue, the nipple areola complex or NAC, and the pectoral fascia together is what is called as a simple mastectomy. Clear hai baat? Chalo. Next important is known as a Halsted mastectomy beta. Now if I talk about a Halsted's radical mastectomy, yaad rakhna, Halsted was a surgeon who performed a radical mastectomy. Now radical is what? Radical means a surgery where we remove the organ along with the lymph nodes beta. ठीक है? So Halsted's radical mastectomy mein he almost removed everything beta. What were the structures removed in Halsted's radical mastectomy? Understand. First of all beta, he did a removal of breast. Okay, so removal of breast tissue was done along with NAC. I've just now written what is NAC, nipple areola complex. Okay, along with that he also removed the pectoral fascia beta, right? Even the pectoral fascia was removed. Till here it is simple only. Now along with that, what else we are going to remove? Along with this beta, we also have to remove. Okay, along with this beta, we also have to remove the level 1, 2 and 3 axillary lymph nodes. Level 1, 2 and 3 axillary lymph nodes beta. And along that beta, we also have to remove the pectoralis major and the pectoralis minor muscle beta. We also have to remove the pectoralis major and minor muscles. Clear? You also have to remove the pectoralis major and minor muscle. Can you see everything has been removed over here? So if you remove almost everything, that is what is called as a Halsted's radical mastectomy. Then we thought, why to remove so many structures if they're not involved? If I can save some structures, let's try to save some structures. And therefore, beta, when we tried to save some structures, beta, during a radical mastectomy, we came up with modified versions, and that will be called as MRM. What is MRM? Modified radical mastectomy beta. Now, when I talk about a modified radical mastectomy, bache, you have to remember in the modified radical mastectomy, we have to remember what other structures to be removed. So here beta, we have to do removal of the breast or removal of the breast tissue will be done. Plus bache, along with the removal of breast, we have to do removal of the NAC, that is nipple areola complex. Along with that, we have to remove the P fascia. What is P fascia? I have told you, pectoral fascia. Okay, till here it is simple. Now along with that, we have to remove plus level 1, 2 and 3 axillary lymph nodes. That's the reason it is radical, right? Level 1, 2 and 3 axillary lymph nodes to be removed. And now plus minus pectoralis minor muscle beta. Okay, plus minus pectoralis minor muscle. Now what do I mean by this? Yaad rakhna, what is always saved? So please remember the structure that is never removed. The structure that will never be removed beta in any of the modified radical mastectomies, answer has to be pectoralis major muscle. Here we try to save the pectoralis major muscle beta in a modified radical mastectomy. It will never get removed. Okay? Pectoralis minor plus minus, because in some types of modified radical mastectomy beta, you remove the pectoralis minor muscle, and in some types of MRM, you save the pectoralis minor muscle. Clear? Hai? Now based on this, whether I save the pectoralis minor or we remove the pectoralis minor, depending on that, let's see the three variants of MRM beta. Let's see the three variants of MRM. Understand first and then we will see. We know beta why we are either going to remove the pectoralis minor, or we are going to cut the pectoralis minor, or we are going to retract the pectoralis minor beta. Okay, to dissect or to remove the level 2 axillary lymph nodes. I hope all of you are quite aware. The level 2 axillary lymph nodes which were there, beta, you know, they were located behind the pectoralis minor muscle. So if I have to remove the level 2 lymph nodes, beta, I need to remove the pectoralis minor muscle, or at least I have to cut the pectoralis minor muscle, or I have to retract the pectoralis minor muscle, right? So to dissect or to remove the level 2 axillary lymph nodes, I have three options with me. Either I have to remove the pectoralis minor, or I have to cut open the pectoralis minor, or I have to retract the pectoralis minor. Okay? So based on that, the three variants of MRM. The first condition which is there, beta. In the first condition, what we do? Understand. Here the pectoralis minor muscle is removed, beta. हम निकाल देते हैं उसको, ठीक है? The pectoralis minor muscle is removed over here, along with okay. So pectoralis minor muscle is removed over here for the dissection of level 2. इसको level 3 हो गया बेटा ये. Corrected, it is level 2 for dissection of level 2 axillary lymph nodes, beta. No issues with this, anybody? And this which is there, beta, is called as the, anybody, Patey's MRM, beta. It is known as the Patey's modified radical mastectomy. ठीक है? तो अगर pectoralis minor muscle को निकाल दोगे, if you are going to remove the pectoralis minor, that is known as Patey's MRM. Next important is, if I am going to, okay, the pectoralis minor muscle over here is incised. Incised means cut. I am going to cut and separate the pectoralis minor muscle, beta, and then you are going to remove the level 2 lymph nodes. So if the pectoralis minor muscle is incised for the dissection of, again, correct over here, level 2 lymph nodes, beta. Okay, for the dissection of level 2 axillary lymph nodes, definitely. Then this kind of a MRM, beta, is what is classically called as the Scanlon's MRM, which, then this is what is known as the Scanlon's MRM. And the third type, beta, here you have to remember that the pectoralis minor muscle is just retracted. Okay, retracted means what? You are just going to pull it back. You are neither going to remove it nor you are going to cut it, beta. Just pull it back and remove the level 2 lymph nodes. And third, next thing which is there, beta, added one over here, that is, यहाँ पे beta, we do not remove the level 3 lymph nodes. I'm not saying level 2. यहाँ पे level 3 ही है. Do not change this now. ठीक है? यहाँ पे the level 3 lymph nodes are not removed. Okay, level 3 lymph nodes are saved over here. The level 3 lymph nodes will not be removed, and this will be called as Auchincloss MRM, beta. Okay, this will be known as the Auchincloss MRM, Auchincloss modified radical mastectomy. ठीक है? तो जल्दी से एक बार, if I say, beta, that for removal of the level 2 lymph nodes, you have also removed the pectoralis minor muscle. You have removed the pectoralis minor. That is called as Patey's MRM. Next, for removal of the level 2 lymph nodes, you have incised the pectoralis minor. You have cut the pectoralis minor. That is Scanlon's MRM. And lastly, for removal of the level 2 lymph nodes, beta, for removal of the level 2 lymph nodes, you have retracted the pectoralis minor. You have just retracted the pectoralis minor. That is Auchincloss MRM. But in Auchincloss, one more thing to be remembered, that in Auchincloss, beta, which lymph nodes are saved? In Auchincloss, the level 3 lymph nodes which are there, beta, they are saved. They are not removed. Okay. In Auchincloss, one more factor to be remembered, and that is level 3 lymph nodes are not removed in Auchincloss MRM. Clear? So these are the 3 points about the various types of modified radical mastectomy. Now let's talk about the next point, beta, and that is nothing else but axillary clearance. Now what is axillary clearance? I've told you, beta, whenever we have to perform a radical mastectomy, we also have to remove the lymph nodes as well. And here we are going to remove which lymph nodes? The axillary lymph nodes. That is what is called as an axillary lymph node dissection or a axillary lymph node clearance, beta. Okay? So now whenever we do a axillary clearance, beta, in a radical mastectomy or a modified radical mastectomy, which how many minimum lymph nodes are to be removed? I'm not asking about groups. I'm not asking about the level. Number of lymph nodes. So please remember, in axillary clearance, beta, minimum 10 lymph nodes are to be removed. Okay? याद रखना, please remember, in axillary lymph node clearance, basically, बच्चे, minimum 10 lymph nodes are to be removed. Minimum 10 lymph nodes are dissected or minimum 10 lymph nodes are removed, beta. That has to be remembered during a axillary lymph node dissection. Has been a previous year question. One thing. Next important, beta, what could be the complications of these axillary clearance? When you make an incision over the axilla and you remove these lymph nodes, beta, what could be all these complications? So the complications would be, first of all, in any surgical procedure, we know that the patient may have bleeding from the surgical site, right? So here also there can be chances of bleeding. Next, there can be chance of wound infection also. Okay, and if there is wound infection, beta, the patient may have a very high risk of flap necrosis. Now, what is basically flap necrosis? Understand. Here I have made an incision. We have created a flap. Now, from that beta, from the axilla, now we have removed all the lymph nodes. Now we are going to place this flap back in place. But beta, if the flap is very very thin, okay, if the flap is very very thin, beta, it may not have enough amount of blood supply, and that is the reason, beta, there will be a high risk of flap necrosis over there. Okay, so either if the flap is very thin or if there is wound infection, beta, the flap may undergo necrosis. Now flap necrosis more commonly happens on a post-operative day 4, beta, commonly. Okay, chalo. Next important, there can be a risk of injury to the nerves. Why, beta? Because in the axilla, we know, beta, there are so many nerves, right? There is the long thoracic nerve, thoracodorsal nerve, axillary nerve, intercostobrachial nerve, right? The medial pectoral nerve, all of these. That is the reason, beta, definitely the patient will have a very high risk of injury to the nerves, beta. So if they ask you which is the most common nerve injured in an axillary lymph node clearance, has been a previous year question. Answer has to be, a lot of people had marked it, pata nahi kya kya. You have to mark it as ICBN. And what is ICBN? Intercostobrachial nerve. Here, beta, when the intercostobrachial nerve is injured during a axillary lymph node clearance, the patient may experience, beta, chest pain and pain in the upper limb, beta, after the surgery. Yes, patient is going to experience chest pain and pain in the upper limb after the surgery. That is the classical feature of a ICBN or intercostobrachial nerve injury. Okay, that is important. Next, beta, yes, even the long thoracic nerve may get injured. It is not the most common, but yeah, long thoracic nerve of the patient may get injured, beta. And if it is injured, I hope all of you are quite aware, long thoracic nerve is also known as nerve of Bell, beta. And if that is injured, there will be paralysis of the serratus anterior muscle, and therefore the patient's scapula, which is there, beta, it will be outwards, and that is going to cause what? That is going to cause basically the winging of scapula, beta. The patient is going to have the classical winging of scapula if the long thoracic nerve has been injured. Clear? Next important, beta, after axillary lymph node clearance, there can be damage to the lymphatics also, and due to that, beta, there can be leakage from the lymphatics, and there can be due to leakage of lymphatics, beta, the patient will have definitely a lot of lymphatic collection in the upper limb. Okay, and that is what is called as lymphedema. Can you see here? The patient underwent axillary lymph node clearance, and after that, the patient, after a few weeks, has come to you with such a gross swelling in the upper limb, beta. This gross swelling in the upper limb is basically due to lymphedema. Okay, yaad rakhna, rather, upper limb lymphedema ka most common cause is a modified radical mastectomy or axillary lymph node clearance itself. ठीक है, surgery ही है. So याद रखना, beta, the patient may develop a upper limb lymphedema on the same side, beta. Okay. Lymphedema can also be one of the important complication. So a lot of times what happens, beta, patient ignore this lymphedema, and due to that, if the lymphedema is going to be long standing, beta, for almost a span of 8 to 10 years, okay, if it is long standing for a span of 8 to 10 years, actually from the lymphatic ducts, beta, the patient can develop a malignancy or a cancer. Yes, patient may develop a secondary malignancy or a cancer from the lymphatic duct, and if the cancer develops from a lymphatic duct, it will be called as lymphangiosarcoma. Okay, and it is also known as what, beta? It is also classically called as the Stewart-Travis syndrome, and that has been a previous year question. That is classically called as the Stewart-Travis syndrome. I'll also talk about that in lymphatics as well, beta, in vascular surgery. So Stewart-Travis syndrome basically, beta, okay, is nothing else but a secondary malignancy, beta. Okay, secondary malignancy, also called as a lymphangiosarcoma. Secondary malignancy, also known as a lymphangiosarcoma, beta. That has to be remembered, which develops due to a long-standing lymphedema in a patient. Okay. Next important, if they ask you what should be the treatment of the patient, beta. So treatment के लिए याद रखना, beta, you can ask the patient to wear arm stockings, beta. Why? Because these arm stockings which are there, they will actually compress, beta, and as they are going to cause compression over here, that will help in the lymphatic drainage properly, beta. First thing. Second important, you will ask the patient to do regular exercises, because regular exercises also are going to help, beta, in drainage of the lymph. And third is the manual drainage itself. Manual drainage matlab, you have to send the patient for a physiotherapy and a proper massage. Because of that physiotherapy and massage, beta, the lymphatics, the lymph which is there, beta, it will drain properly. Clear about? These are the treatment options for a lymphedema in a patient. Now next important, if I talk about beta, ये lymphedema, ठीक है. Next important, if I talk about, is nothing else but what is the most common complication of a modified radical mastectomy overall. So do remember beta, in a modified radical mastectomy as a surgery overall, if I ask you, in a MRM beta, the most common complication will be this. If at the end of the surgery beta, you have forgot to insert a drain, a Romovac suction drain, then there can be collection of fluid beta at the surgical site like this. And that is what is called as a seroma. Yes, collection of serous fluid is known as a seroma beta. And this is what is classically called as beta, the most common complication after a modified radical mastectomy. Another question of NEET PG. The most common complication of MRM or modified radical mastectomy is a seroma, collection of serous fluid. Okay? If they ask you what should be the treatment in the patient, if the patient comes to you with a seroma beta, okay, if the patient comes to you with a seroma bache, then the treatment is nothing else but we have to take a needle and an empty syringe. We have to insert the needle inside the swelling and we have to aspirate all the serous fluid from that swelling beta. Okay, so that is nothing else but aspiration has to be done. But after aspiration of the fluid beta, still there is a very high risk of recurrence. So what we should do, we should apply a pressure bandage over that side beta so that the recurrence is going to be lesser. Okay, so aspiration followed by pressure bandage. Okay, aspiration followed by a pressure bandage has to be done. Hopefully that's clear now. Okay, so the most common complication after MRM, you have to remember, answer has to be a seroma. Okay, and the treatment, if they ask you, answer has to be a aspiration followed by a pressure bandage. Bache. Hopefully that's clear to all of you now. That is important. Next important is beta is sentinel lymph node. What is the sentinel lymph node? I've already told you bache that sentinel lymph node is nothing else but a first draining lymph node of any cancer. Okay, and in case of breast cancer beta, we know it is going to be the axillary lymph node. The first draining lymph node of a cancer is called as a sentinel lymph node. Now when it is important, understand, for example beta, a patient had a breast cancer and her axillary lymph nodes were enlarged beta, so obviously they were palpable. So when the axillary lymph nodes are palpable, we know that the cancer has spread to the axillary lymph nodes and we have to go for a removal of these axillary lymph nodes beta, right? But in case if the patient is having a breast cancer beta but her axillary lymph nodes are not palpable, if her axillary lymph nodes are not palpable, does it say that the lymph nodes are not involved? No, there can be a risk even if they are not palpable beta, still the cancer might have gone to them. Okay, भले ही वो palpable ना हो, but cancer तो फैल सकता है ना उधर तो, right? So that is important beta. So usually you have to remember, in these conditions, when you are not sure whether the cancer has gone to these lymph nodes or not, in those conditions beta, we have to go for a procedure called as a sentinel lymph node biopsy. Okay, so what is the indication? Indication of sentinel lymph node biopsy is when the lymph nodes are not palpable. When the lymph nodes in a patient of cancer are not palpable, we should send the patient for a sentinel lymph node biopsy. Hopefully that's clear to all of you. Now when I talk about a sentinel lymph node biopsy beta, please remember there are two techniques which will be there. The first one will be called as the blue dye technique. The second one will be called as the radionucleotide technique beta. Okay, important is beta, if I talk about a blue dye technique, what is that? Understand, we will inject beta a blue color dye, usually a methylene blue dye or a isosulfan blue dye beta. We will inject that dye around the areola of the patient. Now when that dye is injected in the periareolar region beta, it will be taken up by the cancer. Now from the cancer beta, this blue dye will go to all the lymph nodes wherever it is draining beta. To all the sentinel lymph nodes, this dye is going to travel. And then when I make an incision over the axilla beta and I open the axilla of this patient, I am able to see these kind of blue color lymph nodes. And all these blue color lymph nodes are which lymph nodes beta? These are your sentinel lymph nodes. If the lymph node is blue in color, that means it is draining the cancer and you have to remove that lymph node, right? That is what is done beta. This is one way beta for a sentinel lymph node biopsy known as the blue dye technique. Another way which is there beta, it is a radionucleotide technique. Now instead of using a blue dye, what I can use a radioactive substance beta in the patient. Here we have to inject a radioactive substance beta in the periareolar region. Yes, around the areola, you will inject a radioactive substance. What is the specialty of a radioactive substance? It is actually going to throw out, or it is going to emit radiations beta. So when I inject this radioactive substance beta, usually a technetium 99 tagged sulfur colloid, it will be taken up by the cancer beta. From the cancer, again it will go to all the sentinel lymph nodes. Again, I have to make an incision in the axilla beta, and now this time I will use a handheld instrument beta, and this handheld instrument is called as gamma camera. अब ये gamma camera क्या करता है? This gamma camera beta, it detects the radioactivity. That means in whichever lymph node beta there will be radiations. Okay, in whichever lymph node is emitting the radiations beta, if I take this gamma camera close to that lymph node, it will start making a beeping sound. Clear hai? So I will take this gamma camera close to each and every lymph node. Now, if it goes close to a lymph node and it immediately starts making a beeping sound, that means this lymph node is emitting radiations. That means this lymph node is having the radioactive substance, and that means this lymph node is draining the cancer. I have to remove that particular lymph node. Clear hai baat? So याद रखना, sentinel lymph node biopsy is done by two techniques. One is called as the blue dye technique beta. In blue dye technique, we have to use, one is the methylene blue dye. They have asked about the dye that we use beta for sentinel lymph node biopsy, or you can also use the isosulfan blue dye beta. These are the two dyes beta which can be definitely used for the blue dye technique. Important is if they ask you what is the most common complication of this blue dye technique, याद रखना, the most common complication of the blue dye technique could be skin tattooing beta. Yes, the problem could be with the skin tattooing. That dye which is there beta, it can actually stain the skin. So that is important. So the most common complication of this blue dye technique is skin tattooing. Now the other complications due to that blue dye technique can be, there can be skin necrosis beta, or there can be anaphylaxis. The dye may not suit the patient, right? Allergic हो सकता है patient. Next is radionucleotide technique बच्चे. If I talk about the radionucleotide technique, याद रखना, in the radionucleotide technique, as I've told you, which radioactive substance has to be used beta? The radioactive substance to be used has to be technetium 99 tagged. It has to be technetium 99 tagged sulfur colloid beta. Technetium 99 tagged sulfur colloid has to be the radioactive substance beta to be used in the radionucleotide technique. And in this you have to remember beta, which camera is used? We have to use the gamma camera beta, which will detect the radiations now. Okay, we have to use the gamma camera which will detect the radiations. Now previous year question in the NEET PG examination, and that was, which is the best technique beta? Which is the best technique to be used for sentinel lymph node biopsy? याद रखना beta, the best technique to be used for sentinel lymph node biopsy, answer has to be combination of both. Yes, combination of both together beta will be the best technique to be used for sentinel lymph node biopsy, right? That is A plus B, you can write. Hopefully that's clear to all of you. That is about the sentinel lymph node biopsy in a patient. Now, if I talk about the treatment beta further, that is nothing else but hormonal therapy beta. Next important, if I talk about hormonal therapy, obviously hormonal therapy will only be possible if the cancer cells beta are having hormonal receptors on the surface. अगर hormonal receptors है surface पे, then only a hormonal therapy is possible, right? So that has to be remembered beta. If I talk about the hormonal therapy now, please remember that. Okay, if I talk about a hormonal therapy bache, it is possible in a ER/PR positive breast cancer, right? If the breast cancer is having the ER and the PR, that is estrogen and the progesterone receptors beta, then only it is possible to block these receptors and to give the hormonal therapy in the patient. Now, if they say what is the hormonal therapy given in a premenopausal female beta, if she is a premenopausal female beta, what is the hormonal therapy of choice? Now, in a premenopausal female beta, we know the source of estrogen is mainly the ovaries beta. Please tell me, in a premenopausal female who is in the reproductive age group beta, can I stop the estrogen production completely? No. Reason beta, she should have her menstrual cycles. She may have to conceive also na. That's the reason I cannot stop her menstrual cycles beta. Therefore, I cannot stop the estrogen production. Second option is, can I block all the estrogen receptors? No, because I cannot block the estrogen receptors on the endometrium. Otherwise, she will again not have any kind of menstrual cycles. That's the reason, beta, I should use such a drug which will have agonist action on some sites, antagonist action on some sites, and no action on some sites. Okay? And such a drug, beta, which has different kind of actions basically on different sites, beta, is going to be which one? Please remember, it is going to be SERM beta. Now, what is SERM? Basically, I have told you it is a selective estrogen receptor modulator beta. It is nothing else but a selective estrogen receptor modulator, and that selective estrogen receptor modulator is something like tamoxifen beta. Okay, so please remember tamoxifen, which is there beta, it has to be the SERM, selective estrogen receptor modulator of choice beta, or the hormonal therapy of choice for a premenopausal or a reproductive age group female. High dose of tamoxifen has to be given. Now, important is if they ask you beta, what can be the most common side effect in this female? The most common side effect is not going to be endometrial cancer. Yaad rakhne ka, the most common side effect is going to be hot flushes beta. Okay, the patient will have a lot of redness and a lot of sweating beta in the face. That is called as hot flushes, and that is considered as the most common side effect beta for tamoxifen or SERMs. Next important, we know beta that this drug which is there beta, it is actually going to have increased risk of DVT. What is DVT? Deep venous thrombosis. Next, this drug may also increase the risk of endometrial hyperplasia beta, and due to endometrial hyperplasia, yes, the patient may be at a risk of cancer, but that is not at all a common side effect beta. That is definitely a rare side effect which may occur only in few patients beta. Okay? The most common side effect for SERM, if they ask you, answer has to be hot flushes bache. Next important now, if I talk about, is the postmenopausal females. Now, if they ask you what is the hormonal therapy of choice in a postmenopausal female, I have already told you beta, the female who has already attained a menopause, in that female the only source of estrogen which is there beta is the adipose tissue, and inside the adipose tissue it is which enzyme? The aromatase enzyme beta, which is converting the androgens into estrogen. So can I block that aromatase enzyme itself? Yes. Reason? She is already a postmenopausal female beta. Okay, even if estrogen is not there, it is not going to affect her much. Okay, so I can stop the estrogen production over here. In a postmenopausal female beta, we have to give aromatase inhibitors in the female. We have to give aromatase inhibitors. And the drug which can be used over here would be, anybody? The drug that is used over here beta is the drug of choice for PCOD, you might have heard, right? And that is nothing else but letrozole, anastrozole. Okay, that could be the drugs beta, or I can use exmustane. We can use exmustane beta. Okay, so please remember bache, what can be the hormonal therapy of choice for a postmenopausal female? You have to remember those are the aromatase inhibitors. Which aromatase inhibitors is the drug of the which can be commonly used? It can be letrozole, anastrozole, exmustane. These can be the drugs beta. Now, what can be a side effect of this drug? The major side effect of this drug beta would be, we know that already the female is postmenopausal. Already she is having less amount of estrogen in her body, and we know estrogen has an osteoblastic action. So obviously, as there is less estrogen beta, the female is already at a very high risk of osteoporosis. Now, whatever was the estrogen in her body beta, we have also stopped that by giving aromatase inhibitors. So obviously, the patient will have a very severe deficiency of estrogen in the body, causing a very high risk of osteoporosis beta. Okay? So that is important to be remembered, bache. The patient will have a very, very high risk of osteoporosis, bache. No issues with this, anybody? Now, if I talk about beta, in this female, as there is a very high risk of osteoporosis, what is the advice that is given? This has been a previous year question of your examination, and that is definitely beta. What is the advice in a postmenopausal female who has been started on a hormonal therapy with aromatase inhibitor? Obviously, beta, she is having a very high risk of osteoporosis. Here, the advice should be to give calcium and vitamin D3 supplementation beta. So always beta, along with these drugs in a postmenopausal female, it's important to start calcium and vitamin D3 supplementation. And if the patient is having fractures, or if the DEXA scan shows a very low T score beta, then definitely you can even start the drug of choice for osteoporosis, and that is going to be somewhat known as bisphosphonates beta. You can give definitely bisphosphonates to a patient. Clear? So calcium and vitamin D3 supplementation. No issues with this, anybody? That has to be remembered. Done? Chalo. Next important beta is going to be chemotherapy in the patient beta. Now if I talk about chemotherapy, okay, chemotherapy is another treatment option we know. So chemotherapy की अगर मैं बात करूँ बेटा, what are the indications of chemotherapy in a patient of breast cancer? So first indication you have to remember beta, it is whenever the patient will have a positive lymph node. तो याद रखना, when the lymph nodes are positive, that means it is actually a locally advanced breast cancer. So therefore we have to give chemotherapy. Second, LABC. LABC मतलब locally advanced breast cancer when there is either involvement of the lymph node or the surrounding structures beta, right? Next important, ER negative and PR negative. Okay, obviously beta, ER negative, PR negative matlab hormonal receptors are not present, right? For example, basal type of breast cancer, I told you, ER negative, PR negative, HER2 negative. In those kind of breast cancers beta, hormonal therapy cannot be used because hormonal receptors are not there. So we can use a chemotherapy in those patients. HER2 पॉजिटिव ब्रेस्ट कैंसर बेटे, यस, अगर बस HER2 रिसेप्टर है, HER2 पॉजिटिव ब्रेस्ट कैंसर, बिकॉज HER2 इज नॉट अ हार्मोनल रिसेप्टर, HER2 इज अ ग्रोथ फैक्टर रिसेप्टर. तो HER2 पॉजिटिव ब्रेस्ट कैंसर में आई कैन यूज कीमोथेरेपी. एंड बेसल टाइप ऑफ ब्रेस्ट कैंसर आई हैव ऑलरेडी टोल्ड यू, ट्रिपल नेगेटिव ब्रेस्ट कैंसर where hormonal receptors like ER and PR are not present, so hormonal therapy could not be used over there. So in that patient we can use a chemotherapy. Now what is the chemotherapy regimes that we can use beta? First is definitely we can go for 6 cycles of CAF or CMF beta. What is basically CAF bache? C for cyclophosphamide, A for adriamycin, and F for 5-fluorouracil beta. Okay, F for 5-fluorouracil. What is CMF basically? CMF में again C for cyclophosphamide, okay, C for cyclophosphamide, M for methotrexate, okay, and F for again 5-fluorouracil beta. ठीक है, these are the CAF or the CMF regime beta which could be used for the chemotherapy in a patient of breast cancer. So 6 cycles of CAF or CMF regime can be done. Next important beta, you can go for 4 cycles of ACP. Now what is 4 cycles of ACP? Understand, 4 cycles of AC, that is adriamycin and cyclophosphamide, and followed by that 4 cycles of P, that is paclitaxel which. Okay, so 4 cycles of adriamycin and cyclophosphamide followed by 4 cycles of paclitaxel. These are the chemotherapy regimes beta which definitely could be used in a patient of your breast cancer. Now if the patient is having a HER2 positive breast cancer beta, if the patient is having a HER2 positive breast cancer, this was a previous year question of your examination, that which is that monoclonal antibody or the drug to be given in a patient who is a HER2 positive case. तो याद रखना बच्चे, HER2 positive breast cancer में the monoclonal antibody that we use for the management has to be a drug called as trastuzumab. Okay, that drug which we give beta has to be trastuzumab, and that trastuzumab is also known as Herceptin. Along with trastuzumab and Herceptin beta, we have to give chemotherapy obviously. Okay, chemotherapy will be an adjuvant one, but yeah, the main drug for 1 year at least we should be given beta is trastuzumab or Herceptin, which is considered as the best drug to be given in a patient of HER2 positive breast cancer. What is the side effect? You have to remember beta, side effect would be just infusion related reactions beta. Okay, infusion related reactions could be a side effect beta. When you give infusion, then the patient may have reactions related to that. Clear it? Okay, clear to all of you? That has to be remembered beta. Next important, let's talk about the breast reconstruction surgery. Obviously beta, in a patient if you have done a breast removal or a mastectomy, the female may want a breast reconstruction also. There are 2 options I've told you. One option is alloplastic silicone gel implants beta, or the second option would be using a flap for reconstruction of the breast beta, and that flap should be taken from her own body beta. Okay, now if I talk about bachche, hopefully done. If I talk about breast reconstruction surgery beta, so breast reconstruction surgery mein, if they ask you which is the best flap to be used, I've told you over there in plastic surgery, the best flap to be used beta has to be the DIEP flap beta. The best flap to be used for breast reconstruction surgery has to be the DIEP flap. And what do I mean by DIP flap, beta? You have to remember it is the deep inferior epigastric artery perforator flap. Here you can see the flap has been named after a artery, beta. That means it is actually a free flap which is taken from the abdominal wall, beta, and it is placed over the breast basically for the reconstruction. But why this is the best flap, beta? Better than a tram flap. Reason, beta, I've told you that in deep inferior epigastric artery perforator flap or the DIP flap, we do not take the muscle, beta. And as the muscles are not taken basically over here in this flap, that's the reason, beta, the chance of abdominal wall hernia is going to be lesser. Clear? If they ask you the most commonly used flap, that we have already discussed earlier, beta, and that is nothing else but a tram flap. Okay? The most commonly used flap, beta, in a breast reconstruction surgery, we know it is the tram flap. That is important to be remembered. Next point that you need to remember, beta, is this pictures you can see, beta. The first picture that we are able to see, beta, what is this first picture suggest you of? This is basically, beta, you can see the breast has been reconstructed with the flap that has been taken. This is a DIP flap, beta. Clear, eh? Next important, you are able to see, beta, here the marking which is done. It is done in which muscle, beta? This is which muscle that has been marked? This is the LD, beta, latissimus dorsi muscle. So basically this flap which is used for the breast reconstruction, beta, is nothing else but a LD flap. ये जो दूसरा flap use किया गया ना यहाँ पे, this is the LD flap, beta, that is the latissimus dorsi flap. Okay? This is the latissimus dorsi flap, beta, which is generally used in this picture over here. Okay? So that is important to be remembered. Now, apart from that, as I've told you, beta, we can also use alloplastic implants as well, beta. Alloplastic implants can also be used, beta, to reconstruct the breast. What are those alloplastic implants made up of? Either they are made up of only the silicone gel, beta, right? These alloplastic implants which will help us in breast reconstruction are only made up of silicone gel, bachche. Okay? And they can also be made up of, beta. They can also be made up of silicone with saline refill. Matlab, the outer covering is made up of silicone, beta, and inside that silicone covering, beta, you can place a saline refill basically. You can keep on changing this saline refill basically. Clear? That is important. So there are two types of alloplastic implants for a breast reconstruction. One is a silicone gel implant and second is a silicone with a saline refill implant, beta, which is placed. Okay, so that is important. Let's talk about, beta, the case of breast cancer in pregnancy. Let's talk about a case of breast cancer in pregnancy. Hopefully that's clear to all of you now. Done with this? So, now if I talk about breast cancer in pregnancy, bache, do remember some important points. If I talk about breast cancer in pregnancy, beta, the incidence of breast cancer in pregnancy is rare. वैसे it is usually seen, beta, 1 in 3,000 pregnancies, beta. 1 in 3,000 pregnancies may have a chance of developing breast cancer. Important is that breast cancer in pregnancy, beta, will have a late presentation and a late diagnosis. You will be like, so why? Reason, beta, even if the patient starts having changes of breast cancer, now the female thinks that it may be due to pregnancy, right? In pregnancy also there are some changes in the breast. Now female thinks कि okay, it may be some changes due to pregnancy itself, so therefore she ignores those, beta, and that's the reason there can be a late presentation. So yaad rakhna, there can be late presentation if there is a breast cancer in pregnancy, because she feels, beta, those are going to be the pregnancy induced changes basically, and these pregnancy induced changes which are there, beta, those are going to mark the those are going to cover up, or those are going to mask the early signs of breast cancer in the patient. Okay, so that has to be remembered. If they ask you diagnosis, beta, we know that diagnosis which is there for any patient of a breast lump or a breast cancer has to be done, beta, by the method of triple assessment itself. It has to be done by triple assessment. So history taking and clinical examination will be done, but then, beta, the patient will be sent for radiological investigation. What is the radiological investigation of choice in this patient? Bolo. Anybody, what is the radiological investigation of choice in this patient, beta, in whom we have to diagnose a cancer? Very good. Please remember, beta, as the female is pregnant, we cannot use a mammography, beta, in this patient, right? And that's the reason. Very good. It has to be nothing else but an ultrasound breast which has to be done. Okay, and along with ultrasound breast, depending on that beta, obviously we have to go for, based on the BIRAD score, we have to go for a true cut biopsy in the patient. The investigation of choice will be a true cut biopsy, but radiological investigation of choice will be a ultrasound in the breast beta. Clear about? So that has to be remembered. If they ask you what is going to be the treatment in the patient beta, तो याद रखना है बच्चे, the treatment of the patient has to be, okay, depending on the stage. Now let's talk about the stages beta. The first condition which is there, the first condition I am saying beta, it is a early invasive breast cancer. Now early invasive breast cancer in pregnancy beta, what are the two options for an early invasive breast cancer? One is a simple mastectomy, second is a breast conservation surgery. I've told you beta, breast conservation surgery is usually not recommended to be done during a pregnancy. Okay, so therefore what is a better surgery with least chance of recurrence? Answer is simple mastectomy. People will be like, sir, how the baby is going to be fed after delivery? Beta, there is another breast, okay, to feed the baby. And even if that breast is not there, you can feed the baby by a formula milk, but you have to save the life of the mother. That is more precious, right? So that is important beta. Simple mastectomy will be the best choice beta for a early invasive breast cancer in pregnancy. But if the female says, Dr. Saab, no, I want to save my breast. If she says definitely she wants to conserve her breast, then we have no other option rather than performing a BCS or a breast conservation surgery beta. But can we perform a BCS? Yes, there can be a possibility. And how? Understand. We can perform a BCS or a breast conservation surgery in her second or third trimester of pregnancy beta, but we will only give the radiotherapy to the patient beta. Okay, we will only give the radiotherapy to the patient once she has delivered. Yes, radiotherapy should be given after delivery beta. Radiotherapy to this female will be given after delivery. That is a possibility beta. Yaad rakhna that BCS could be done in the second or the third trimester of pregnancy, and the radiotherapy has to be given after delivery beta. That could be a possibility. Then a BCS could be done. Okay? Next important is LABC beta. What is LABC? Locally advanced breast cancer. If the female is having a locally advanced breast cancer beta, then what is the management normally? Neoadjuvant chemotherapy followed by a modified radical mastectomy followed by a radiotherapy. तो यहाँ पे क्या करेंगे? Understand बच्चे, यहाँ पे in the second or third trimester beta, we will start the chemotherapy. You will be like, sir, why not in the first trimester? I hope all of you are quite aware that in the first trimester, the organogenesis of the baby is going on. If you give any chemotherapy drug in the first trimester of pregnancy, there will be a very high risk of congenital anomalies or abortions in the fetus. That's the reason beta, second or third trimester mein, we have to start with the neoadjuvant chemotherapy beta. Okay, and after that definitely beta, once the tumor has been downstaged, then we can go for a MRM beta. What is MRM? Modified radical mastectomy bache. Followed by MRM, that is modified radical mastectomy has to be done. Okay, and after that definitely beta, we have to go for radiotherapy, and that radiotherapy has to be again given after delivery bache. Radiotherapy is again given after delivery. Okay, so what is done in the locally advanced breast cancer during pregnancy? Second or third trimester may start the neoadjuvant chemotherapy. After that immediately go for a modified radical mastectomy. But the radiotherapy will only and only be given beta after the delivery itself. Okay, chalo. Next important beta is a condition about male breast cancer. A very short topic again. Male breast cancer की अगर मैं बात करूँ बेटा, okay, male breast cancer which is there. How much is the incidence of a male breast cancer beta? The male breast cancer का incidence is even less than 1% बच्चे. तो याद रखना, the incidence of male breast cancer is even less than 1%. Yes, 99% cases of breast cancer are seen in females only. Less than 1% cases may be seen in males. Now, what are the risk factors beta similar to female? The risk factors for a male breast cancer could be hyperestrogenemia. Yes, increased levels of estrogen in the blood beta is going to be considered as one of the most important risk factors for a breast cancer in a patient. Next important beta is bilaterally undescended testes. Reason beta, I hope all of you are quite aware, bilaterally undescended testes is known as cryptorchidism, and in that patient beta, the testes of the patient will be not properly developed. Rather, the testes of the patient will be underdeveloped beta, they will be hypoplastic, and that is the reason beta testosterone will not be released. So if testosterone is not released beta, all the androgens get converted to estrogen over here. Okay, so that is important. Next beta, androgen insensitivity syndrome. In this patient beta, you might have discussed in gynecology AIS, androgen insensitivity syndrome, also called as testicular feminization syndrome. Genotypically, beta, the patient is a male, 46XY. Just phenotypically, by the appearance, the patient is a female, beta. So in this patient also, beta, there are bilateral undescended testes, and this patient has a receptor resistance for the androgens. Matlab, the androgens cannot bind to their receptors. That's the reason the amount of androgens is very, very high in the body. So all that androgens are converted into the estrogen by the aromatase enzyme. And that's the reason, beta, this patients you may see that these patients, though they are males, beta, but they have large feminine breasts, okay, due to excess amount of estrogen in their body. So therefore, they will have a very high risk of breast cancer, beta. Okay? Or a patient of Klinefelter syndrome. What is Klinefelter syndrome? It is 47XXY. Normally, a male should have one X chromosome. Here, there are two X chromosomes, beta. One extra female chromosome, which is there, beta, will cause more extra estrogen production in the patient's body. And that is the reason, beta, you know, the patient will also have gynecomastia. See, gynecomastia is not a risk factor for the breast cancer, beta. It is basically the excess amount of estrogen in the body, which is the risk factor for breast cancer. Clear about? And with gene mutation, we know, beta, for male breast cancer, it is the BRCA or the BRCA. Which one? 2 gene mutation, right? So it is the BRCA or the BRCA2 gene mutation on chromosome number 13. And BRCA2 is also associated with P cancers, beta, that is pancreatic cancer and the prostate cancer as well. Okay? Now we know, beta, the diagnosis which is there even in a male, beta, would be done by the same technique. Okay, the diagnosis even in a male breast cancer, beta, is done by the triple assessment itself. Staging will be done, and after that treatment will also be done by the same thing. So diagnosis and treatment is exactly similar, beta, to a female breast cancer. That has to be remembered. Okay. Next, beta, is a condition which is very closely related to the breast cancer, beta. And this condition which is very closely associated with breast cancer is what is known as, anybody, is classically called as, beta, okay, Paget's disease of nipple. Okay. The next condition that we need to talk about, beta, is nothing else but Paget's disease of nipple, beta. If I talk about Paget's disease of nipple, bache, here you are able to see this. Okay, क्या दिख रहा है? The nipple which is there, beta, of the patient appears completely dry, beta. Yes, there is completely dry and a eczematous nipple. Yes, it appears like eczema, na? But the difference is what? Eczema is a bilateral condition, beta. But Paget's disease of nipple which is there, beta, it will be a unilateral condition. Yes, it is a unilateral eczema-like condition of the nipple, beta, and due to this, there is complete destruction of the nipple areola complex, as you are able to see. Completely, the nipple areola complex has been destroyed over here, beta. So Paget's disease of nipple is nothing else but a chronic unilateral eczema-like condition. Okay, chronic unilateral eczema-like condition of the nipple, beta, which leads to destruction of the nipple areola complex. Now, please remember, beta, as I've told you that Paget's disease of nipple is basically a superficial manifestation of an underlying malignancy. Iska matlab, if a patient comes to you with a Paget's disease of nipple, it is 100% sure that the patient is having some or the other kind of malignancy or cancer inside her breast. Yes, you may not be able to feel, beta, a lump definitely in the breast, but the patient is surely having a breast cancer. And it can be which breast cancer, beta? I hope all of you are quite aware that what opens at the level of nipple, beta? We know that the ducts open at the level of nipple. So that's the reason, definitely, beta, here the patient may have some kind of cancer inside the duct. And that is the reason you are able to see the manifestation over the nipple, beta. Clear about? So yaad rakhna, we know Paget's disease of nipple is a superficial marker or a manifestation of an underlying malignancy. And that underlying malignancy can be any of the ductal malignancy, like either it can be DCIS, that is ductal carcinoma in C2, or it can be IDC, the most common, invasive ductal carcinoma, beta. So either of the ductal cancers can be associated with the Paget's disease of nipple. If they ask you, bache, that what is going to be the investigation of choice in the patient, so remember, bache, the investigation of choice in this patient is going to be, beta, okay, a punch biopsy. The investigation of choice has to be a punch biopsy, beta. Yes, you have to take a biopsy of the nipple, beta, And punch biopsy में बेटा actually a biopsy is taken from a smaller area but it is very deep beta. ठीक है, so that is what is called as a punch biopsy. So investigation of choice for a Paget's disease of nipple is punch biopsy, and when we do a punch biopsy, we are able to see very classical cells beta in the patient's skin or the epidermis. As you are able to see, these are the classical cells which are seen beta, right? So these are nothing else but the Paget cells in epidermis which are seen. These are nothing else but beta the Paget cells in the epidermis which will be seen beta. That is a classical feature in the Paget's disease of nipple. Okay, you are able to see these broader Paget cells inside the epidermis or in the skin of the patient. If they ask you about the treatment beta, what should be the treatment in the patient? So yaad rakhna beta, treatment you have to treat the underlying cancer itself. Why? Because please remember, when you treat the underlying cancer, you will do a staging, then you will treat it. So in most of the conditions beta, you had to do a mastectomy. जब mastectomy करोगे, we have to remove the nipple areola complex. So any which ways beta, if you treat the underlying malignancy, the Paget's disease gets treated on its own. Okay, so that is important. So treatment is nothing else but here we have to treat the underlying malignancy beta. Here we have to treat the underlying malignancy. No issues with this, anybody? Chalo, very good. Next important beta if I talk about is another condition beta which is a tumor itself in the breast, which is, and that tumor of the breast was a recent NEET PG question 2024 beta, and that is nothing else but phyllodes tumor beta. Now until now we were talking basically about a breast cancer or a breast carcinoma beta which was arising from the epithelium. Now we are talking about the sarcoma beta which is arising from the mesenchymal or the connective tissue of the breast beta. Clear about? So now let's talk about beta the phyllodes tumor basically. If I talk about a phyllodes tumor in the breast beta, if I talk about a phyllodes tumor in the breast, that is also known as cystosarcoma phyllodes bache. Phyllodes tumor in the breast is also known as cystosarcoma phyllodes beta, also called as the Brody's disease. ठीक है, तो phyllodes के तीन नाम याद रखना है. First is phyllodes tumor, second is cystosarcoma phyllodes, and third is Brody's disease beta. Now, as I've told you, it is not a tumor from the epithelial tissue, rather it is a tumor from the mesenchymal or the connective tissue beta of the breast. Okay, it is a mesenchymal tumor arising basically from the connective tissue beta. That has to be remembered. First thing, we know, please remember beta, that phyllodes tumor which is there, 90% cases of phyllodes tumor are going to be benign in nature beta. याद रखना, 90% cases of the phyllodes tumor are going to be benign. It is mainly a benign tumor beta. It is mainly a benign tumor. That has to be remembered. More common cases are going to be benign itself. No issues with this. Only 10% cases could be malignant. If they ask you it is more common in which age group, yaad rakhna beta, that phyllodes tumor which is there, it is going to be more common in the 3rd to 4th decade of life beta. It is more commonly seen in the 3rd to 4th decade of life. In the 3rd or 4th decade females beta, this condition is going to be much more common. Hopefully that's clear to all of you now. This condition is going to be much more common in the 3rd or 4th decade of life. That is important. Next important is, here you can see beta, the phyllodes tumor which is there. This has been a previous year image based question from August 2020 FMG. You are able to see such a huge breast mass beta. Yes, a massive breast tumor will be seen in cases of phyllodes beta. Phyllodes rather I would say beta is the largest breast tumor. Yes, if they say largest breast tumor, answer has to be phyllodes tumor. So but beta, by looking at the tumor you may feel na okay, it is going to be very aggressive and very malignant and all of that. No, as I've told you, 90% cases are benign only. And beta yaad rakhna, though it seems to be very gross beta, please remember that the phyllodes tumor, whatever is the size of phyllodes tumor beta, does not matter. It will never invade the pectoral fascia. Okay, yaad rakhna, it will always remain superficial beta. It will never invade the pectoral fascia. That has to be remembered. Even if it is a malignant tumor beta, it will never go below the pectoral fascia. That is the speciality of phyllodes. And that is the reason beta, as it will remain above the pectoral fascia, you may be able to move the phyllodes tumor beta. Yes, it is slightly mobile. Though it is very, very huge, it is slightly mobile. Not very freely mobile like a fibroadenoma, but yeah, it is still slightly mobile beta. Clear about? Chalo. So beta, as I've told you, it is a huge tumor. That means it is going to be rapidly growing breast mass beta. Sometimes they may say slowly growing also, just to confuse you. ठीक है. So some cases of thyroids may be slowly growing, because this time in the NEET PG they confused with this. Is that slowly growing? ठीक है. So they may say slowly growing. At times it is very rare, but yeah. So mostly it is rapidly growing breast mass, beta, and you are able to see, beta, the skin does not appear normal. Here there are some skin color changes which are seen. The reason is, here the blood vessels which will be supplied in the skin, beta, due to the tumor, the blood vessels which are supplying the skin will get compressed, and that's the reason the skin will have decreased blood supply, leading to ischemia, and that is going to cause cyanosis or the color changes on the skin. Clear hai baat? So that is important, beta. The patient is going to have rapidly growing breast mass. Along with the rapidly growing breast mass, beta, you will be able to see the skin color changes, and these skin color changes are seen due to pressure necrosis, right? The skin color changes are usually due to the pressure necrosis of the skin itself by the mass. As I told you, beta, it doesn't invade the pectoral fascia. It does not matter how much big it is going to be. It will never invade the pectoral fascia. So it is mobile, beta. When you palpate that tumor, it may be mobile. That has to be remembered. One important feature. Next, beta, you are able to see this tumor which is there, beta. It will have a irregular appearance. That irregular appearance which is there, beta, it may be described as the bosselated appearance or a bosselated surface. Okay? So they may say definitely, beta, the tumor is having a bosselated appearance or a bosselated surface. Okay? Next important, beta, if they ask you that what is going to be the investigation of choice, so please remember, beta, the investigation of choice in the patient which is there, the investigation of choice in this patient is, beta, is going to be a true cut biopsy itself. The investigation of choice, obviously the whole triple assessment process will be followed, beta, because there is a breast lump. But finally, the investigation of choice, if they ask you, answer has to be true cut biopsy itself, beta. And once I do a true cut biopsy, I am able to see a very classical feature on the histopathological examination, and that histopath was given in the recent NEET PG, as I've told you, beta, and that was this histopathological examination which was seen in the picture. What is seen over here? Here you are able to see, beta, there are leaf-like structures which are usually seen on the biopsy, right? So if leaf-like structures, okay, if there are leaf-like structures, beta, which are usually seen on the biopsy or the histopathological examination of the patient, these are very, very classical of thyroid tumor. Yaad rakhna ye baat. Leaf-like structures on the biopsy, beta, this is very, very classical of a thyroid tumor, beta, that has to be remembered. Clear hai? No issues with this, anybody? If they ask you what is going to be the treatment of the patient, beta, if they ask you what is going to be the treatment of the patient, so yaad rakhna, beta, the treatment of my patient has to be wide local excision. Yes, though it is a so big tumor, beta, we just have to remove the tumor with some normal margins, beta. 1 to 2 centimeters margins has to be taken. You'll be like, so why? As I've told you, it is benign and it is non-invasive. तो क्यों जरूरत है फालतू में पूरा ब्रेस्ट निकालने की? So beta, here definitely the treatment has to be a wide local excision. Okay, the treatment has to be a wide local excision, beta, with 2 centimeter margins. Okay, a wide local excision with 2 centimeter margins has to be done. No issues with this. But there are certain conditions, beta, where I may need to go for a simple mastectomy, beta. And what are those 3 conditions where a simple mastectomy may be required in a patient of thyroids? First, if it is a case of recurrence, beta, or if it is a very large tumor, or if it is a malignant tumor, beta. ठीक है? तो याद रखना 3 conditions where a mastectomy may be required in thyroids. First is if it is a recurrence case, beta, पहले भी निकाला था, अभी भी है. Second, beta, if it is a large tumor, like you are able to see in the picture, such a large tumor, or if definitely, beta, it is a malignancy. Okay. In this condition also, beta, we don't go for any radical mastectomy. क्यों नहीं radical? Because remember that the thyroid tumor never spreads by the lymphatic route, neither spreads by the lymphatic route nor spreads by the hematogenous route. ना ही वो lymph से spread होता है, ना ही blood से spread होता है, बेटा. It only spreads by direct invasion. That's it. So that's the reason, even if it is malignant, beta, we don't have to remove the lymph nodes at all. So therefore, we have to only go for a simple mastectomy. We can only go for a simple mastectomy. ठीक है? तो mainstay of management is usually a wide local excision, but in these 3 conditions, a simple mastectomy may be indicated. Now, as I've told you, malignant thyroids, which is there, beta, if it is there, it can spread, but malignant thyroids will only and only spread by one route, beta, and that route that route definitely by which the malignant phyloid can spread is known as direct invasion. Okay, so the malignant phyloids which is there, which it can only spread by the direct invasion. And when I say the malignant phyloid spreads by direct invasion, what is the most common site of metastasis then? Obviously, beta कहाँ फैल सकता है if it is only spreading by direct invasion? If it is only spreading by direct invasion, beta, the most common site of metastasis is going to be the lungs. It is going to be the lungs, beta. No issues with this, Vinny? Okay, please remember that it does not spread by lymphatic route, it does not spread by hematogenous route. Okay, so that is important to be remembered. Brain like structure नहीं है बेटा, usually leaf like structure it is more commonly referred to as. ठीक है, that is important. If I talk about beta the fibroadenoma, the last part of the breast tumors basically. If I talk about a fibroadenoma बच्चे, now what is a fibroadenoma? See, oma means a benign tumor beta, adenoma means a benign tumor arising from a gland. And fibro, why? Because this benign tumor of the breast beta will have a lot of fibrous tissue inside it, and therefore when you palpate this tumor beta, it will feel firm or it will feel even harder beta. ठीक है, so fibroadenoma is the most common cause of breast lump. इसका मतलब whenever a patient of breast lump comes to me, the first differential has to be a fibroadenoma. It is the most common cause of breast lump in a female. Next important, it is the most common benign tumor of the breast as well beta. Yes, it is the most common benign tumor in the breast as well. Age, it is very important to be remembered beta. Fibroadenoma is very common in very young patients, either the adolescent females beta or young adult females. It is very common beta in extremely younger females. 15 to 25 years of age group is commonly affected. Here beta, as it is a benign tumor, it is going to be a very slow growing small lump beta, and that lump which is there beta, it is going to be painless, right? The patient will have a painless. And why firm? Because I've told you a lot of fibrous tissue will be there. So it will be a painless firm breast lump beta. It will be a painless and a firm breast lump which will be there. On examination, if you hold this tumor beta and if you try to move, it will be freely mobile beta. This is a very classical finding of fibroadenoma. It is freely mobile, and that's the reason beta, this fibroadenoma, as it is freely mobile beta, it is also known as breast mouse. Okay, it will also be called as a breast mouse. As it is freely mobile beta, it is also known as breast mouse. That has to be remembered. Another important point to be remembered beta, and that is, what is the investigation of choice? Please remember beta, the investigation of choice for a fibroadenoma has to be a ultrasound, because see, the female will come to us with a breast lump. So we have to start the triple assessment. When I start the triple assessment, history taking, clinical examination is done. Next step is radiological investigation. For that, you will send her for an ultrasound. Q ultrasound, because you can see the age group of the female beta, it is 15 to 25. So less than 40 hai, so radiological investigation of choice is ultrasound. Plus minus, I am saying, plus minus a true cut biopsy or FNSC beta. Plus minus a FNSC or a true cut biopsy. You will be like, so why plus minus? Because beta, it is a benign tumor. And as it is a benign tumor beta, if my radiologist gives me a score of BI-RADS 2, अगर मेरा radiologist बोलता है कि डॉक्टर साहब her score is BI-RADS 2, मतलब it is 100% benign. What is the next step for BI-RADS 2? Nothing else but a routine follow-up or a routine screening to be done. If he says BI-RADS 3, what has to be done? Nothing else but a short interval follow-up after every 6 months. Only if he says beta, if it is BI-RADS 4 or BI-RADS 5, अगर वो बोलते हैं कि डॉक्टर साहब लग रहा है कि BI-RADS 4 या 5 है, then in that condition I will send my patient for the next step, that is FNSC or a true cut biopsy. Clear है? तो single best answer definitely could be ultrasound in majority of the patients beta. In some patients definitely when it is suspicious we may go for a FNSC or a true cut biopsy. If they ask you what is the treatment, I've told you beta, for all the benign breast tumors the treatment is nothing else but observation and follow up beta. You can go for a observation and follow up beta in this patient. Observation and follow up has to be done bache. Close follow up to be done. Okay, so observation and close follow up to be done. Now, are there certain conditions where we need a surgical excision of a fibroadenoma? Yes beta, there would be certain conditions where a surgical excision may be required. Okay, so I'm just writing some cases may need a surgical excision beta. Some cases may need a surgical excision. And what are those cases beta of fibroadenoma which may need a surgical excision? So that indications have been asked in your examination also. Remember those few indications beta where a patient needs a surgical excision. चला है? Now important is beta those conditions where a patient of fibroadenoma may need a surgical excision is going to be previous year question, which is the most common indication for surgical removal or surgical excision of a fibroadenoma. If they ask you, so the most common indication for surgical excision of a fibroadenoma has to be what beta? It has to be cosmetic. The most common indication which is there beta, it has to be cosmetic basically. Okay, the most common indication for a fibroadenoma, okay, has to be cosmetic beta. Next, what are the indications? See, first, if it is painful, obviously it is causing pain, one reason. Second, if it is painful beta, we know that benign lumps are usually painless. If it is painful, that means it can be a sign that it is turning into a cancer or a malignancy. Next, if there is rapid increase in size, we know that fibroadenoma is a benign tumor which should grow slowly. But if there is rapidly increase in size beta, that is suggestive of a malignant conversion again. Next, if there is a family history of breast cancer beta, if the female is having a family history of breast cancer, then there is a very high risk that this lump may also develop into a breast cancer in the female. That's the reason you better go for excision. And next beta, if it is a giant fibroadenoma ka size kitna? When it is more than 5 centimeters in size beta, if the fibroadenoma is more than 5 centimeters in size. So the two questions which have been asked from indications beta, it is this one beta. One, what is the most common indication for surgical excision of a fibroadenoma? Answer is cosmetic. Another, which fibroadenoma has to be resected? Answer was more than 5 centimeters of it. Nowadays, beta, we also have minimally invasive surgeries or scarless surgeries, beta, for fibroadenoma which are available. Here we don't have to take sutures, beta, because a very small incision will be done. And these are going to be the first one which is there. It is called as a radio frequency ablation beta. With the help of a radio frequency waves itself beta, we are actually going to treat the tumor. Okay, so one is definitely a radio frequency ablation. The next one is a mammotome. Mammotome is basically a vacuum assisted surgery beta, with which you can do a removal of the fibroadenoma, but from a very small incision. You just have to insert that vacuum probe inside it. Okay, now beta, if I talk about this, see, I commonly do not perform a true cord biopsy in a patient of fibroadenoma. But in case if I do, or when we do a surgical removal of that fibroadenoma, I hope all of you are quite aware, whenever you remove any kind of mass from the body, you always send it for histopathological examination after removal to check which kind of mass is it. Okay, so यहाँ पे when I send it for histopathological examination, 6 July question of your exam beta, I feel 6 July ये था. So यहाँ पे बेटा the patient was given this kind of a picture, and what was this? So here you are able to see this dark pink which is there now. This is nothing else but your glandular tissue. Can you see the glandular tissue in the patient of fibroadenoma appears to be compressed? Why this glandular tissue are compressed beta? Reason बच्चे, because there is so much of fibrous trauma. There is a lot of fibrous trauma beta, and due to that excessive amount of fibrous trauma, the glandular tissue gets compressed over here. And these compressed glandular tissue which is there beta, doesn't they look like horns of reindeer beta? Okay, don't they look like horns of reindeer basically? बारहसिंघा के सींग जैसे लग रहा है. So definitely beta, these are also that reindeer which is there beta is also called as antler. So this is classically known as the antler sign beta. Okay, it is classically known as the antler sign beta. So histopathological examination beta in a patient of fibroadenoma is going to be the antler sign. Okay, histopath examination in a patient of fibroadenoma will show you the classical antler sign beta. And last point from fibroadenoma, that is definitely here beta in this patient, when I do a mammography beta, when we do a mammography in this patient beta, we are able to see a very classical feature. Yes, mammography is not commonly done, but if I do a mammography in a patient of fibro beta, definitely in these patients you are able to see a macro calcification. Why macro? Because it is a benign tumor, and this macro calcification in patients of fibroid adenoma beta is classically called as the popcorn calcification, right? This macro calcification in patients of fibroadenoma is known as popcorn calcification. I hope all of you are quite aware. Popcorn calcification on mammography is a feature of fibroadenoma breast, and popcorn calcification beta on chest x-ray is a feature of pulmonary hamartoma or lung hamartoma. Clear about that? Is important. Want to call off the session or want to continue? है कोई बचा हुआ? ओके चलो, ठीक है, चलो लेट्स कॉल ऑफ द सेशन फॉर टुडे। आई नो इट्स टू मच फॉर टुडे, सो लेट्स कंटिन्यू टुमारो। छोटा सा टॉपिक बचा है, मैक्सिमम 1 घंटा भी नहीं लगेगा फॉर दिस, आधे घंटे में भी हो सकता है, लेट्स सी। 45 minutes maximum would be required for this topic of breast benign conditions बची है बस breast की, that we'll discuss tomorrow and then we'll start with thyroid and vascular surgery for tomorrow. Yeah, हाँ बोलो। what? Good night, take care.